and thank you for joining me today for Big Ideas in Eating Disorders. In this series, we hear from people in the field of eating disorders who share with us their personal and professional journeys, experiences, reflections, and ideas in ways that never quite get represented as such in standard academic conferences and publications. I'm Kathy Pike, and today I'm delighted to be joined by Professor Eric von Furth. For over a decade, Dr. von Furth has been professor of eating disorders in the Department of Psychiatry at Leiden University Medical Center. He has been the director of Riverdownen Eating Disorders Ursula, a center for excellence for eating disorders in Leiden for more than 2 decades. He's past chair of the Dutch Academy of Eating Disorders, past president of the Academy for Eating Disorders, and has an enormous wealth of experience in the field. We're delighted to have you join us today, Eric.
Thank you very much, Kathy. It's a pleasure to be here and to talk to you today.
Thank you. So let's start at the beginning with just growing up years. What did you imagine your professional career would be?
Oh, that's a tough question. I come from a family of medical doctors. My father was an internist. My brother is a psychologist and a neurosurgeon. My sister is a professor in pediatrics. So my daughter is fourth generation MD, doing her PhD in transplantation surgery. So it runs in the family. And so when I was, I think, 15 or 16, I really wanted to study, go to med school and become a surgeon. That was actually what my brother, of course, fulfilled that task for me. So I started off doing medical school, and I found it horrible. And both content-wise and from a personal perspective, I found it, I kept being confronted with my father's history. He was, at the time, he was a relatively famous Dutch physician. He was, I think, in 1976 when I did my my high school finals. He was the most cited professor in medicine in the country. So
that's quite a legacy.
It is, and I was actually when I went to, I think it was histology, the professor said to me, "Are you the son of?" And that has constantly followed me. And he said, "Oh, but I'm sure you know all this stuff. Shall I just give you an A so you can go home?" Which was ridiculous,
right?
And I had several of these kinds of interactions, and as an 18-year-old, I found it very difficult to deal with.
I'm sure.
So obviously I flunked and I got into psychology, which I liked a lot more.
And found your own path.
I did, but truth be told, I am now a professor at the same university hospital where my father has been a professor for 40 years. So all things come together in a way.
But you got there on your own terms. So
yeah.
What were those? How did you get into psychology? And when you got into psychology, did you know where you would wind up in terms of specialty?
After I wanted to be a surgeon, I sort of switched to being a psychiatrist. And obviously I didn't succeed, but then psychology was a really good second. And in 1984, I did an internship at a family therapy unit, which was part of a child and adolescent psychiatry at Utrecht University. And the guy who ran that place was a very tall Belgian family therapist who had just spent a couple of years at Salvador Minuchin's in Philadelphia. And Minuchin at the time was interested in eating disorders. So when my boss came back to Holland, he said, "We're going to do eating disorders." And so as an intern, I had to write up all the reports of the interviews of the psychiatrist and the family therapist, and we saw one patient a week. And so my first training is family therapy. So that's how my interest in eating disorders started off.
Right. And what were the dominant ideas that came from Mnuchin around eating disorders? I think some of which hold up and some clearly don't.
For me, it meant that my view of working with individuals with eating disorders and teenagers was family-based from the beginning. So it was everything we did was family-based, which I think was very interesting. And after my internship, I wrote my own research grant, and in the end got it funded. It took some time, on expressed emotion and eating disorders. And of course, expressed emotion looks at parental attitudes towards an individual with an illness, and looks at things like criticism, hostility, warmth, emotional over-involvement, which also sort of reflects or should reflect family dynamics, and is something you can actually intervene on, which is interesting.
Yeah. So, Eric, on your service, how would you describe the range of services that you offer and the population that you're serving?
The range is large. So we have e-mental health on the one hand, anonymous e-mental health. We have an e-community called Proud to Be Me. We have a small intervention called Feedback, which we've tested in 2 large RCTs. Then we have a large outpatient unit with lots of groups. In the Netherlands, we do a lot of groups in group psychotherapy, featuring CBTE, but also psychomotor therapy or other sort of connected therapies. Then we have a day treatment unit where we can have up to 20 patients for 5 days a week. And we have an inpatient unit with 21 beds for the most severely ill. So essentially, we offer the full range of services. We do children and adolescents, we do adults, we do elderly, all ages, all genders, all eating disorders. At any given moment, we have about 1,100 patients in care, and we see about 650 patients, new patients every year. So, and
big service.
The Ursula, we employ about 130 people. I think it's, for Dutch standards, it's a big service.
I think by most standards, it's a big service.
There are some that are a lot bigger in Germany, for example, and some commercial ones in the US, but we are, of course, non-commercial, where all of our treatments are reimbursed by health insurance, with very few limits to the duration of treatment, for example, which offers us a relatively great freedom in how we treat these patients and for how long we treat them.
So in the Netherlands, there's an insurance system. Is it a universal insurance system? Can you describe a little bit more about how it works, seeking care in the Netherlands?
We have a universal healthcare system, which means that every individual aged 18 and over needs to have health insurance. By and large, it's private health insurance, but the rates are very reasonable. So I think that I pay per year what an average American pays per month. And children are under the age of 18 are automatically covered by their parental health insurance. And all specialist medical treatments, and that is what we offer, are covered by health insurance. There's a very broad range of sort of treatments that are being covered by health insurance.
So you're working in a health system where everyone's required to have insurance coverage. If they don't have, even if it's a low cost, if they don't have their own funds, is there a national system that provides a safety net for those who can't afford their own insurance?
Even if you're on welfare, you'll have health insurance.
Mm-hmm.
Um, there's a yearly deductible of 385 euros.
Uh-huh.
That's about it. That's what you pay out of pocket.
Uh-huh. So everyone's covered.
Everyone's covered.
And in the US and in other parts of the world, I know as well, access to care is a big issue.
Yeah.
So even if you have coverage, it can be difficult to get care in some parts of the world. Is that true in the Netherlands also? Or do you have data, or do you have a clinical sense that when people need care, there's capacity to deliver the care that's needed?
The answer is both yes and no. So the general practitioner is the gatekeeper to specialized care. So everyone has a GP, and the GP is the first line of defense, and he or she decides whether or not you need specialist care. And there's GPs are very careful, I think, not to refer too many people to specialist care. So you would never go and see a specialist without going through the GP. So that's one important filter, I guess, in the healthcare system. Mm-hmm. Because like everywhere else, we have certainly in the industrialized Western world, we see an increase in healthcare costs on a macro level, and we see a decrease in the number of healthcare professionals. Mm-hmm. So there is the demand for healthcare, and certainly for mental health care, is always larger than what can be provided, and what on a macro level the government would budget.
Mm-hmm. We've talked a bit about healthcare systems. We've talked about a bit about ways in which societies are potentially more toxic related to the specific issues that we're concerned about with mental health, with eating disorders. You've got an eating disorder service that serves 1,100 people at any given moment in time. You're seeing a lot in terms of what this story is and how serious eating disorders can be. I'm wondering if we can move into this discussion around whether you're seeing more. And I also, maybe first question is, what language do you think is the right language when we talk about more serious, more severe and enduring, more chronic eating disorders? Clinically, how do you reference this group that you see as being more ill, right? There are lots of different terms that people use. What do you feel is most accurate? And who are you most concerned about in terms of being most vulnerable in that regard?
Yeah, that's an interesting topic. It's, of course, obviously, I'm not a native English speaker, but I do love language, and it's. I have great difficulty with the terms that we generally use. Things like severe and enduring eating disorder instead of chronic. In Dutch, the patient organization coined it long-standing eating disorders, and used an abbreviation to address these individuals. Terms like terminal anorexia, I have great difficulty with. I think in the depression field, they talk about chronic depression after 2 years. We are hesitant to talk about a chronic anorexia nervosa after 10 years. Mm-hmm. We have, as a field, I think in general, have great difficulty in calling something a chronic illness. Mm-hmm. I'm not talking about chronic individuals. I'm talking about an illness. Mm-hmm. And
so in your system, your health system, the term chronic feels appropriate, and patient groups, that resonates for patient groups as a chronic illness?
No,
No,
it doesn't. I think I'm the outlier. So
I see. Okay.
it's like abbreviations like SEED. In Dutch, it would be LES, which is long-standing eating disorder.
Okay.
And so I think in our field, we find it difficult to name things for what they are.
Uh-huh. I see.
And
So you're saying these are longstanding conditions that we would call chronic conditions. Let's call them chronic conditions.
yeah, yeah,
Got it.
which says
What's the
nothing
advantage?
about the individual, but it says something about the illness, about our lack of power of interventions in a way.
Mhm. Right. So calling it a chronic condition or identifying that there are individuals who have eating disorder symptoms, syndrome, burden over a long period of time, that some patient groups would prefer to call long, severe and enduring, or long-standing. Chronic it could be another term that we use. The reality is that these folks are really burdened and
Yes.
really, and the eating disorder is consuming their lives. And you have written about, you've talked about these issues of what do we do as healthcare providers? How do we understand our responsibilities as healthcare providers for these individuals who are so burdened, who are so impaired by the eating disorder? What do we do about it? How do we define who they are? How do we describe who they are? And what do we do about it? And then what do we do if one of these patients no longer wants to live? And so I want to move into your big idea around this topic, because it is a big idea.
It's a big topic, more than an idea. But just that, before I get into that, my colleague Rita Sloff did some research on how patients define their recovery.
Mm-hmm.
And one of the things that she sort of pointed out is that there's quite a large group of individuals who still have some eating disorder symptoms, but who consider themselves recovered.
Mm-hmm.
I thought that was very meaningful, not so much from a research perspective when it comes to defining recovery, but who am I to define recovery as a clinician?
Right.
Why don't we listen to patients much more when it comes to recovery?
That's right.
And not be too have too many norms around that.
That's right. Yes. How do we define recovery? And absolutely, there's a place for understanding that individuals who are burdened with these conditions may define recovery very differently, very differently from the healthcare and syndrome, the symptoms of the syndrome, right? For most people who have eating disorders, recovery is a bigger story than that, and has to do with quality of life and relationships and meaning and purpose and so on. So when that's gone, when patients don't feel like they have a chance at recovery or have given up on recovery, what's your experience with that? How does that present clinically for someone? And what is the practice in the Netherlands around understanding this aspect of reckoning with life and death?
No. One of the things, at least that we experience, perhaps because we're a tertiary center, is an increasing number of individuals who say they want to die. And in my experience, I would say 99.9% of the individuals with an eating disorder, and specifically people with restrictive anorexia nervosa, do not want to die. They want to live. Mm-hmm. But there seems to be, at least, but that could very well be my referral bias, a group of relatively young individuals who say they want to die. And these young individuals in general, I'm talking about 20 to 30-year-olds. I mean, from my perspective, that's very young. And
Mhm.
these individuals generally have had a very long history of eating disorders, 10 years, sometimes 15 years, multiple treatments, evidence-based treatments, forced treatments, force-fed treatments, but that has not resulted in lasting recovery. And I find that very, very worrisome,
Mhm.
because we should avoid death if we can, but these individuals actually want to die. And in our services, we struggle with this on a daily basis because obviously we don't have the answer. And like everywhere else in the world, even with really good care and treatment, people die from eating disorders, like they die from other serious mental and somatic illness.
Right.
But again, we try to avoid that, but it's a huge struggle in trying to achieve that. And how do you do that with someone with a BMI of between 9 and 11?
Your observation is that individuals are coming to treatment, or they're
Yes.
coming to the center, and they are in despair. They
Mhm.
say they want to die. Do they say they want to die, or do they say they don't want to live, or is that not a meaningful distinction?
I think it is a meaningful distinction, and I actually think that most, not all, but most people who say that they want to die actually don't want to live. They find living so extremely difficult. I'm
Mhm.
thinking about a patient that we have admitted now who's really had, like many of these patients, I must say, so much extreme bad luck. She's survived multiple long-lasting sexual abuse periods in her life, and in many ways it's really you can understand why she finds life so difficult.
Mhm.
She finds it, she cannot talk about it.
Mhm.
She's completely engulfed by her eating disorder and can only think about not wanting to gain weight and losing weight and actually wanting to die. And she wants to die. She tries to die by starving herself. That really is what she's trying to do. And that is almost impossible in this country. The only way to do that is to completely isolate yourself somewhere in the woods and not contact anyone. But
Mhm.
that's not how it works. So
Mhm.
these individuals end up in hospital time and time again.
So, Eric, let me ask you, you're describing somebody who is really in a state of despair, who really has expressed that she doesn't want to live, she wants to die. Could you share with us the general big overview? I know this is a big topic, but sort of a big overview to contextualize this discussion in the Netherlands. What are the laws and practices around end of life for somebody with a mental health condition like this?
That indeed is a big topic. Since 2002, the law on the termination of life on request and assisted suicide act became legal, and obviously I'll just call it euthanasia, but euthanasia is most commonly requested for elderly patients with severe somatic illness in the end stages of their life. From all deaths in the Netherlands, only 4% are actually cases where euthanasia ended their life. So even
4% of individuals with mental illness.
no, with all illnesses.
With all illnesses. Okay. And then of the euthanasia cases, what
Yes.
percent is mental illness?
That's 1%.
Okay. So
So,
it's 1% of 4% of deaths.
so euthanasia in general is relatively rare,
Mm-hmm.
which I think may be a common misperception in the US, but if it's only 4%. And within the people that receive euthanasia, only 1% are people with mental illness. And this practice has the number of individuals requesting euthanasia with a mental illness has increased slightly. In 2010, this was still very rare, around 2 cases per year, but it has increased to between 60 and 90 cases in the past couple of years.
Mm-hmm.
Um,
So that's a dramatic increase.
yes, I think that's a really dramatic increase. And there's, of course, obviously a lot of debate about how we should deal with this increase in requests.
Mm-hmm.
And one of the things that just my personal opinion, but there's an inflation in terms, I think, in the words people use. And I think that the requesting euthanasia for some is a way to express their extreme despair around their illness and their life. Whilst in the old days, they might have said, I just feel desperate.
Mm-hmm. Mm-hmm.
So again, this is context, because if euthanasia is legal, and it is legal in this country, then you can also request it.
Mm-hmm. Right.
It's interesting that there's the demand and the.
Right. So euthanasia is legal in the Netherlands. It's now legal for mental health conditions. There was a paper recently published by colleagues. I think all of the colleagues are in the US, Jennifer Gaudiani, Alyssa Bogetz, and Joel Yeager, entitled Terminal Anorexia, 3 Cases and Proposed Clinical Characteristics, that has caught a lot of attention and many different reactions. As you look at this conversation that's been catalyzed by this paper, from the perspective of being in the Netherlands, what do you see that makes sense, or from your experience of the Netherlands, what caution would you have, and what wisdom? You're ahead of the game in some ways.
First of all, I think it's really, really important to realize how different the US and the Dutch healthcare system are. It is very hard to compare interventions, and certainly when it comes to this sensitive topic of death, in 2 healthcare systems that are so completely different, where access to care is so completely different, where reimbursement of care is so different. So I cannot be judgmental in any way of the US system, because it's not the system I work with. I think that what Gaudiani and colleagues did is they was very brave in many ways, in that they addressed a topic which every clinician dealing with serious eating disorders must encounter, but is rarely discussed or rarely treated. So I remember a couple of years ago at one of the Academy for Eating Disorders conference, it was huge news that a clinician said that they did not send away patients that were so severely ill that they may perhaps die from the illness. They would actually care for them and offer them sort of a palliative care process. And I was completely shocked, because we've been doing this forever.
Mm-hmm.
How can this be new?
Right.
So addressing a topic of how do we deal with individuals that find life so difficult that they want to end their life, and not by suicide, because we know suicide is a huge problem in eating disorders. Suicide is very, very lonely. And very traumatizing for everyone, and it's probably never a good ending.
So what I'm hearing from you, Eric, in terms of the big idea that we're talking about here is the seriousness of end of life for a small group of individuals, but a group that otherwise winds up really isolated and alone in the world of eating disorders. And you've mentioned a few things that I think are really important to how you think about it and the way you would frame this big idea around. You started talking about being sure that individuals had access to care and had access to evidence-based care. And that then part of that, if an individual has had access to care and high quality care and continues to be burdened in a way that feels unbearable, we need to have these conversations around it, that the conversation needs to be initiated. The request needs to be initiated by the patient, but there needs to be space for that kind of conversation. Am I capturing that right? Are there things that you would edit or highlight differently?
You're capturing it brilliantly. Yes, I think that's very important. Not having this conversations with patients and families is not taking them seriously. Mm-hmm. Discharging them from your services when these requests are made is could be seen as an aggressive move. You don't want to be confronted with the fact that your patient may want to die or is dying. So caring for individuals in these sometimes final stages, but certainly in with very serious burdens, I think is very important. Mm-hmm. One of my patients is a woman. She's in her 50s and she's had obviously multiple treatments, all sorts of treatments, but evidence-based treatments. And she now has a very low BMI and is slowly deteriorating. Her body is slowly giving up. And I see her every week. Mm-hmm. And I talk with her family, I talk with her daughters, and I cannot predict the future. I'm trying to help get her the best care that she needs at that moment. If she wants an admission, sort of a booster admission to get the structure of the inpatient unit and perhaps gain a couple of kilos, that's fine. If she doesn't, that's fine too. Mm-hmm. I'm not going to force her. I'm not going to pester her with treatment. I'm following her path.
Mm-hmm. You know, your comment there takes us back around, Eric, to this idea of needing to hear from patients about what quality of life is, and the work that you referenced and the work that we worked on together with Sarah Wetzler and who defined based on a review, dimensions of recovery and quality of life that matter to patients, that were things like supportive relationships, hope, identity, meaning and purpose, empowerment, and self-compassion. Those were the domains that emerged from the review that Sarah led, that we worked on as a team. When those things don't exist, the quality of life is extremely low. You've got a patient now who may be saying, all of those psychological domains aren't working for me, and my body is giving out, and I've had this disorder for decades, and I don't see recovery ahead. And you mentioned that you continue to see her, which, you know, in the US, this whole movement around palliative care is really a waking up to how do we hear what patients want in terms of quality of life today. Patients have been telling us this, right? If we would only listen.
Yeah.
Yeah. And so there's a discussion around palliative care and listening to patients and what they want. And then there's a reckoning, and you're saying that you have lived with this as a clinician, that there have been patients who you've tried to meet in terms of quality of life and what they want from life, and nonetheless, life was too much of a burden for them, and they chose to end their lives through the programs, the
Through
practice
euthanasia.
through euthanasia.
Yeah.
From my perspective, is extraordinarily humane from a certain perspective.
Glad
It
you said.
also raises people's concerns that, yeah, but we don't have the best treatments that work for all patients, so that if everyone got those treatments, they would work. And so we need to do better in terms of our treatments. We need to do better in terms of access to care. Your point about ensuring that people had access to care and had access to evidence-based care, but even our evidence-based care has huge deficiencies. So there's worry that that embracing a model of palliative care and euthanasia will take healthcare providers off the hook.
I think that's black and white thinking. It's, of course, we need to do better. Our best evidence-based treatments are rather mediocre. In many other fields of medicine, similar things occur. There are some really good and some good treatments for certain forms of cancer. But even with the best treatments, some people end up in a state where nothing can be done. They've had all the treatments, and in this country, at an end-of-life stage, people can request euthanasia, and they receive euthanasia from their doctor. It's the same for mental illness. We even with the best treatments, prolonged treatments, given all the deficiencies and the pluses and the minuses, we cannot, not everyone gets well. Some people die. And a humane death, a good death, at least from my perspective, may be better than suicide.
Mm-hmm.
It's a very difficult, emotional, sensitive topic.
So as you look forward, what do you think we need to do as a field to advance this conversation?
I think we should very much focus on access to care, improving the quality of care and of treatment, getting more people into recovery, but listening to our patients at the same time, listening really, really well. I've never learned more than listening to my patients, listening to their definitions of recovery, listening to their suffering, listening to unbearable suffering, and not walking away from these conversations, I think is very important for all of us in every healthcare system, because you cannot step outside of your healthcare system. Our US colleagues have to deal with their system, which is a problematic system from my privileged Dutch perspective, but patients have to deal with it, clinicians have to deal with it.
You made a comment earlier that having the conversation is healing as a first step, that when people are thinking about these issues, if our patients are thinking about these issues, but understand because of the various systems in place that this is not a topic they can discuss with us, then where do they go with it? And that's a real failure, right? Of capacity to embrace all that's burdening them. And it occurs to me, Eric, that it's very similar just generally to talking about end of life, and that that's a difficult conversation for many people. And as people get older, they want to talk about what they want and how they hope their lives will conclude here on Earth. And if we can embrace those conversations, there's so much healing in and of themselves. So I agree with you that the US has a lot to learn from different systems, and the Netherlands is one. There are other countries that have policies and practices in place where if we could collect the data and bring it forward and have real conversations that include our patients, I think we learn a lot.
Yeah. Although I would say that getting the US to adopt universal healthcare would really be a very important first step.
Yeah. So
from a population perspective, that would make such a big difference.
No question. No question. And that takes us really to a timely conclusion of our conversation, which is, as you say, each health system has its strengths and weaknesses, and there are significant aspects to the US health system that create gaps in care, and takes us back around to your point about having the conversation about euthanasia only in the context of a system that is also pushing hard to ensure access to evidence-based care.
Yeah.
We really can't have one without the other.
No, we can't. That would be a huge injustice and a failure of us clinicians.
Yeah. Well, Eric, I want to thank you for joining me today for Big Ideas in Eating Disorders. This is a big idea, and it's one that has many facets. And I really appreciate hearing from you, learning from you about your own clinical experience and the laws and policies in the Netherlands, and hope that we can responsibly, ethically, and constructively continue this conversation as a field. Thank you.
Thank you. And I hope this leads to many new conversations.